So,
So I'll stop sharing.
yeah, and then we'll put ours up
Sure.
and then we'll.
Do you have this more set up? Am I going to see the other participants, or is this more, these are the people I'm going to see and everyone else is just available in the chat?
No, the people that turn on their cams, you will be able to see.
Got it. Okay.
We just always hold them in the waiting room, so we do a little bit of admin work at first and then open
Understood.
it up.
Sure.
It's time for us to open it, but
Are we ready to go?
we're ready.
Okay,
Yep.
here comes everybody.
Hi, everybody. Welcome to this special version of PMP Pals Hope Zoom. Give everyone just a few minutes to join.
I see some folks here that I know.
You sure do. Yes. Yeah, and feel free to turn on your cams and wave at Dr. Weiner.
Hi, everyone.
So let's.
We're coming in.
Okay, well, we'll give everyone just a second, but I will share my screen for a moment. Okay, can everyone see that?
Yep, we can see it.
Okay, great. So again, welcome to our Wednesday, August 2nd, Hope Zoom call. Today we have a very special guest, Dr. Joshua Weiner. We'll give some background on Dr. Weiner in a moment, although I don't think he needs an introduction. PMP Pals, we're the world's oldest global volunteer-run organization that gives hope to patients and caregivers with an appendix cancer diagnosis and related conditions like PMP. And this always messes me up. Oops. Now you probably bear with me. Okay, some disclaimers. So we provide, forums for patient fellowship and support, but we're not licensed to provide medical advice. And so patients must seek licensed physicians who are qualified to develop and provide appropriate treatment plans for your situations. I don't think Dr. Weiner has any scary images or graphics, but just a heads up, some of the topics might be scary. By participating in these forums, your identity and health condition may be shared with the public. For our surgeon presentations, we do record and we do post these. We do edit them though. So you have the ability to hide your image and name, but we can't guarantee anonymity. And then by participating in this call, you give us permission to share your likeness with other patients, caregivers, physicians, and related parties. About us, our extremely popular program is Hope Zoom, where we have our twice weekly live video meetings with periodic physician presentations. And we learn so much from each other, and we offer each other hope and support. And so for those of you that are not regular Hope Zoom participants, we really invite you to join us. They're typically Wednesdays at 6 p.m. Eastern and Saturdays at 11 a.m. Eastern, although this Saturday we are on a break. The physician presentations, like we're having today, it's part of our resilient resources library of information that we share with our patient and caregiver community, but also offer the opportunity, particularly like we'll do today, to interact with Dr. Weiner. We have our annual meetup. So last year, post-COVID, we went back to meeting in person. This year our meetup is October 27th and 28th in Milwaukee, Wisconsin. And so look for our posts about that. And we hope you can join us there. Our most popular program are Get Well and More Cards, where we send cards of encouragement, support, or just caring to our patient community, and those experiencing some challenging times. This is a legacy program that our founder started, Gabriella Graham, back in 1998. And so we have been doing these cards for over 25 years. We also send bare bottom bears to patients, another legacy Gabriella Graham program. One of our volunteers, in honor of her sister who was a patient, sends these out. And there's nothing like receiving your bear when you're in the hospital, or you need a reminder of all the love and support we have for our patients. In addition to our Hope Zoom calls, we offer one-on-one mentorship and support. And you'll see the A team on this call with the PMP Pals backgrounds that are open 24/7, fielding patient calls, and it's certainly our pleasure. We've been there, and we're here for you whenever you need us. You can also find us, info@pmppals.net if you have a question. We're on social media, and then our website, pmppals.net. And support. We're totally donation driven, and your contributions, whenever you're inclined, certainly help us keep our programs going. So with that, I am going to, now I'm having the same problem you are, Charmaine.
Back to share screen and then stop
share. Yep.
There
I am. And so quickly, by way of introduction, I know I dove right in, but I'm Adele Jason, and I'm coming up on 12 years since my CRS HIPEC, patient volunteer and a member of our board. Charmaine.
Also a patient, diagnosed 25 years ago, and my CRS HIPEC 14 years ago. I'm on the board with Adele and volunteer for other things, and so glad to see so many people here today. Thank you for being here.
Yes, Jamie.
Hi, everybody. I'm Jamie. I'm a patient as well. I was diagnosed in 2019 and had CRS and HIPEC in 2020 at the height of the pandemic. That was fun. And I'm glad to see everybody today.
Connie.
Hi, everyone. I'm Connie. My husband is the patient. He was diagnosed in 2015, and we live in South Florida, and I'm very happy to see everybody here tonight. Welcome. I'm also one of the volunteers and mentors with PALS. Thank you for coming on and being with us tonight.
Yes, and our guest, who truly needs no introduction, is Dr. Joshua Weiner. Dr. Weiner is an associate professor in the Division of Surgical Oncology at Emory University School of Medicine. He is one of our esteemed specialists. I mean, he knows, this disease. So many of our patients have had Dr. Weiner as their surgeon. Specializes in HIPEC and other treatments for this disease. And I'm just going to turn it over to Dr. Weiner to let him get started. Dr. Weiner, welcome. Thank you.
Perfect. Thank you for having me. So I'm going to share my screen. The first thing, I was asked to talk about Actually, not really about HIPEC today. Although that is going to be an option for the questions afterwards. But we get a lot of referrals at academic centers and large volume centers, whether they're academic or community, about appendix tumors in general. And a lot of people don't really understand what those are. And so I felt that, so Adele and I spoke, and she gave me a couple questions that she thought y'all would be interested in. And then we got a couple more questions yesterday. So first, that's my email. And you guys are more than welcome to email me directly if you have any questions or you want to talk afterwards. So we're going to talk about some questions. And the two main questions that I was asked to address was, okay, I've been diagnosed with a lamin. What the heck is that? And what do we do next? And then the second one was, what is a goblet cell carcinoma? Because it's a very kind of hot button topic right now in the appendix world, and people don't really understand what it is. And so just have a few slides about everything, and pretty much, about maybe 20, 30 minutes of talking on my part, trying to keep it not that data heavy, but, keep it at a point where we can all understand it together, and then open it up to you guys to ask questions. But we did get a couple questions before last evening, and these were some of the questions about what is the difference between PMP and appendix cancer, difference between goblet cell and signet ring questions, and then what is mucinous adenocarcinoma, how is it different? And so I'll go through all this, and then I'll address that as well, so that hopefully we can answer those questions. And of course, any questions you guys have, please put in the chat, and they'll let me know, because I suck at looking at the chat. So I can admit that. So why don't we get started? So the basic objectives based on, I always want to have objectives, so make sure that I get through everything, and that I don't get off target, which often happens because I like to talk because I'm from Boston, is what is a lamin, and what is it not, i.e. not appendix cancer? How do we manage these surgically? Because this is unfortunately very kind of confusing, both for patients as well as for physicians. And then we'll talk briefly about goblet cell carcinomas. So this is the most common referral that we get, actually, other than for patients with peritoneal carcinomatosis or pseudomyxoma. And what it is that I just had surgery. The doctor found something they didn't expect. The appendix came out, and I have this thing called a lamin. And the question is, what the heck is it? Do I need more surgery? Is it a tumor? Is it cancer? Where are you? And what if it was ruptured, perforated? And what happens if they took it out but didn't get it all out? What do we do with those patients? So let's start at the beginning. So those of you who have gone to see specialists or have had HIPECs or cytoreductive surgery, or maybe were not candidates for it but have gone through this, understand what it is. But we'll pretend that I don't know. So the appendix, or any organ, can make cancers or tumors based on the different cell types within that organ. And with the appendix, you actually have kind of the spectrum of tumors, from benign, this lamin or low-grade appendiceal mucinous neoplasm, all the way to appendix cancers, which are essentially no different in terms of the way they develop than colon cancers. And all of us know what a polyp is, at least in the literature, right? We've read about it in the paper, we've seen these things because we all get colonoscopies, right? And so what a polyp, though, is kind of described, though, really is let's be honest, we are not made out of PVC piping. Our gut's job is to absorb or to transit through. In order to do that, it has to have kind of mucus or other surface liners to try to move things along. And so these cells don't last forever. The body turns them over. And unfortunately, the body can make a mistake. When it does that, the body usually kills those cells. But if it doesn't, they form a benign tumor called a polyp. Okay. And that is why we do colonoscopies, because we want to catch those before they get large. And so we can't cut them out without surgery, or before they make another mistake as they start to grow and get the ability to invade. When a tumor is able to invade, that's a cancer. Okay. So what is a lamin? This tumor, this low-grade appendix mucinous neoplasm, essentially is a polyp, a mucus polyp of the appendix. And as long as it doesn't do anything, it just sits there, then it's benign. It doesn't spread, it doesn't do anything. However, unfortunately, sometimes it ruptures and it bursts. And if it does that, that's where you get what we call pseudomyxoma, or nowadays we changed the term to be more inclusive. We call it peritoneal carcinomatosis, which just means that you have disease within the abdominal cavity. And so that, I think this is a key point, is a lamin is just a polyp. In and of itself, it's nothing else. Unfortunately, we can't take it out with a colonoscopy. So if we find it, as most surgeons do, they'll remove it with an appendectomy, or removal of the appendix. The interesting thing is that about 10 to 13% of these patients who have the lamin will also have other lesions in the colon, usually just polyps. And so we always suggest getting a colonoscopy if you're not up to date. What up to date means is in the eye of the beholder. Sometimes it's, usually most of us, as long as you had a negative colonoscopy with no polyps, within 2 years, we don't make you redo it. But if it isn't, we would ask you to update it. The other thing that's important to know is that not every pathologist is used to looking at these things. And what we found is that when we've reviewed, this was actually a study done at UPMC, which I was initially involved with. I didn't finish it up, so I'm not in the paper. But when we look at tumors of the appendix, either low grade or high grade, you may have heard of a Hammond, which is just a high grade equivalent, or even mucinous adenocarcinomas, and we review those at a high volume center, whether that's a community center or an academic center, it turns out that we oftentimes will downgrade from a higher stage, so what they thought was an invasive cancer or a true cancer like a colon cancer, but it's in the appendix, or even upstage, although that's pretty rare. So we always want to review the pathology. So this is a key point. So it's a spectrum from essentially a benign polyp all the way to cancer within the appendix. And then there's something called a goblet cell carcinoma, which is kind of almost over here. And we'll talk about that one at the end because it's a little bit of a weird diagnosis compared to the rest of kind of more standard appendix tumors, which come from the lining of the appendix. So the question becomes well, okay, great. So we have this lamin, I had surgery, the doctors took it out. What do we do next? This is important because it's very much misunderstood by the physician population as well. We oftentimes will have patients referred to us who've had a lamin diagnosed and then not only had an appendectomy, but had a right hemicolectomy on top of it, which is a colon cancer operation or an appendix, a true appendix cancer operation, but it's actually not required for an isolated lamin. And this is important. We actually have guidelines, both in surgical oncology world, there are 2018 Chicago consensus guidelines, which many of you probably have heard of because it's the peritoneal malignancy, surface malignancy guidelines. And it's in, from appendix, colon, gastric, mesothelioma, et cetera, all the way down through. It's being updated currently. We're currently working on that. It should be updated within the next year. And the American Society of Colorectal Surgeons in 2019 have consensus guidelines also related to appendix tumors. And they're both in agreement that as long as your lamin or your appendix, what used to be called a mucocele or an cystadenoma, the appendix, as long as it's isolated and it's nicely confined, you're done once you've removed that. But yet, unfortunately, people don't always know that. And so this is why we're trying to get this out so that people understand that you have to treat something appropriately, but you have to be careful in terms of over-treating as well. So that's the first question that people ask, do I need it? But okay, let's say you had that appendix. Most oftentimes people with lamins, they get the appendectomy secondary to what they thought was an acute appendicitis. So they had pain, they got a CT scan or had something else, and they found this tumor, this dilation of the appendix. And so the surgeon goes in to take it out thinking it's acute appendicitis and it's inflamed. And so for acute appendicitis or an inflamed mucocele or lamin, you oftentimes can't get all the way down to the base. And so sometimes you get a little bit of tumor at what we do, we usually staple it off with a stapler. And sometimes the pathologist will look at it and say there's either cells of the tumor at the base or there's mucin at the base. And this is the second most common question that we get is, what do I do with that? So the short answer, as I put here, is that if you have something like that, it's complicated. And these are the patients should be coming to someone who deals with this all the time. Why? Simply that it's not a simple answer. The first, of course, is we want to confirm the diagnosis. So if anyone has found that they had a lamin, it should be confirmed at a high volume institution by a pathologist who sees them all the time to make sure that it's actually real and it's not a cancer or not even a lamin, because there are other things that make mucin that probably don't need to be worried about. Then you want to get your colonoscopy. And then the question is, what do you do? And so if you have a positive margin, there are lots of small studies, but the studies that get quoted and thrown around a lot in the literature is this study by Arneson from 2015. So it's already been 8 years ago. And as you can see, there were 16 patients. Lamins are extremely rare, okay? And they're not reported a lot in the literature. This took 16 years to get 16 patients. Now, there are many other studies that looked at MD Anderson has. We have some. There are various studies that have looked at this, and overall, we've developed a much larger kind of cohort, if you will, of these patients who've had this. But the truth of the matter is that it's a very low recurrence rate, even with a positive margin. So if you have a colonoscopy and there's no obvious disease on the inside, meaning there's no obvious mass where they stapled at the appendix is connected to the colon. And so there's a little hole, an opening right there. And so the endoscopist, the GI doctor, looks inside and can see that. And if there's no tumor there, and when you actually review, these tend to not come back. Interestingly enough, when patients who've undergone, this is again one of the examples, but when you have a larger volume of patients, you look over the source of literature, most patients don't even have any disease so if I take out the colon or I take out the cecum, which is the first part of the colon where the appendix is connected, we don't usually see tumor there. So basically, this was then updated more in a review setting. They put Yale just recently gave their own experiences of 8 patients. And they reviewed a lot of cases in literature, not all the cases, but a significant number, 60 cases. And of those 60 cases, 1 had residual tumor, and over many years, 4+ years of follow-up for all these individual patients, we don't see any obvious disease. So it seems, at least from the current literature, and we're learning more and more about this every year, that if you had unfortunately had to get an appendectomy or taking out your appendix for a lamin because they found it, maybe for appendicitis, or you're getting a CT scan for something else, they take it out, but unfortunately they do have the margin is positive. You can manage this just by following it closely with imaging. And closely with imaging is not as close as one would think. Closely in this case means every 6 to 12 months. Because if this is going to grow back, it grows back very slowly, and it's, again, very rare. But we usually include colonoscopies in this, and we have an algorithm here at Emory where essentially we get a colonoscopy at a year after appendectomy. We follow you twice a year with imaging, transitioning to MRIs, so we don't have to use radiation. And then we follow up to 5 years. At 5 years, currently, there's not enough data in our mind to suggest that we should stop following. So we follow once a year, at least for 10 years. But as we get more and more data, that may change and may continue on forever. Unfortunately, if we see late recurrences, or it may be able to be stopped at five years as the evidence becomes more mature. But again, as you can see, there are very, very few patients in the literature right now to be able to draw really good conclusions. So then the next question is, and this is the more common, unfortunately, is patient you had a lamin, you had acute appendicitis, and when the doctors took it out, they found a little bit of mucus or mucin right next to it, next in the kind of the right lower quadrant there. Or that not only they find some mucus, but they found some epithelial cells or lining cells from the appendix sitting in those mucin pools. And so the question is, does that patient need a HIPEC, right? Because the thought would be, of course, logically would be, well, there's cells outside, there's mucin outside. Unfortunately, this is going to lead to that pseudomyxoma or that peritoneal carcinomatosis we talked about. And so we should go back in and clean it out and give the patient a HIPEC with the chemotherapy intraabdominally to hopefully decrease the risk of recurrence. Well, turns out that it's not that simple. And in fact, most of us who do this type of work, who follow patients for an extended period of time, I follow many patients who've unfortunately had ruptured lamins. And it turns out that very few patients actually recur, and most patients recur within the first 2 to 3 years if they're going to recur. So this is an example. This is an often quoted paper from 2018, when they looked at 41 patients who had appendicitis, most of them, but they had a ruptured lamin with no evidence of distant spread in the abdominal cavity. So they weren't 100% going to require the cytoreductive surgery to remove the remainder of the disease. And so it was taken out with the original appendectomy, or in this case, one right colectomy and oophorectomy with taking out the ovary with the uterus. And out of 25 patients who had perforation, in total, the other 2 were the patients with the colon and the ovary. Only 2 recurred in 2 years. So not a large volume of patients, but very low recurrence rate. And this is important because the question is, when we're looking at surgery doesn't come without, it's not free, right? We can't, you can have complications from surgery or long-term ramifications. If you take out the right colon, you could have persistent diarrhea. You can have weight loss, inability to control your stools. It doesn't happen in many patients, but it could. You can have problems with scar tissue or adhesions, can lead to bowel obstructions. All these things can happen, and then it's a real concern. And so we don't want to operate on patients if we don't have to. And then the other question, of course, is that if we choose not to operate, because this is a shared decision, of course, in this setting, then is it safe? And so it seems, at least from this initial kind of larger volume study series, that it seems to be safe. So one of the other presenters who's been here in the past, Dr. Baumgartner, in a cohort, kind of a large group from around the country, put together kind of a series of patients, 217 patients. So that's a fairly large number for this rare disease. And almost 40% of these patients either had rupture, either on slides, meaning when they sliced the appendix, they looked at it and the wall was ruptured, or grossly in the operating room, they could see a hole in the appendix. And of those 40%, about 1 in 5 didn't actually have any mucin. So it was just a rupture in and of itself. So high risk, if you will, that potentially stuff had gotten out. Okay. But a fair number did have mucus outside, and in a not insignificant number had actually cells from the appendix lining that were outside the appendix as well. And of those 40%, we had 74, these 74 patients went on a surveillance program instead of surgery. And only 7 patients recurred in 5 years plus. And the median time of recurrence in the middle of the road was about a year and a bit. And in fact, generally speaking, pretty much everyone had recurred after, within 2 to 3 years. Again, as similar, if you will, to the patients who had the cells at the cut portion of the appendix, that margin positivity. So why is this important? Because here at Emory, and it's a little controversial, but this is a common algorithm that's used throughout the high volume centers, and I think it's reasonable. We do the same thing for the margin positive. For patients who come into us who've never had labs drawn, we draw something called tumor markers. For those of you who've dealt with this, those are the CEA, the CA125. These are proteins that are present. It doesn't mean that you have metastatic disease, but they sometimes can be elevated in a patient with this type of disease process. And if they're elevated, it's more concerning. So we get a baseline tumor marker. And the other thing is that sometimes they're not elevated to begin with, but they can begin to elevate over time, which is usually suggestive, if you have a trend towards elevation, towards concern for tumor recurrence. We always review the pathology, and if we can, we try to make sure we can look at the entire appendix. And the reason is that sometimes we can see a couple slides that may have an invasive cancer, which is a totally different thing than a lamin, right? And we'll talk about, we kind of mention it, but I'll explain more in detail. But we also are looking for rupture or perforation. We're looking for lining cells or neoplastic cells outside the appendix on the surface, things like that, to suggest higher risk of recurrence. We also review the operative reports from the surgeon. And I personally, and I think most of us do this, try to actually contact the surgeon who did the operation and discuss what he or she found, because that's almost as important as the operative report. Oftentimes, they'll remember something they did not put in the operative report or didn't indent the operative report, such as, yeah, you know what, I did see some mucus along the abdominal wall or something along those lines. Or did they get it all out if they saw it? Assuming that they did, we usually get a baseline CAT scan, usually around that 6 to 8 weeks after surgery, just so we have a baseline understanding of what's going on. And then every 6 months for 2 to 3 years, usually after a year, we change over to MRIs again to decrease the radiation exposure. The other reason is that MRIs are actually more sensitive, meaning they can pick up small things. Sometimes they're too sensitive and they pick up things that actually aren't what we're looking for or confusing. But it's, again, we take the good with the bad, and the MRIs are much more kind of sensitive for looking at peritoneal disease if you have the correct protocol. MRIs, unlike CT scans are pretty standard. You either give contrast, don't give contrast, abdomen and pelvis, etc. But MRIs are dependent on the way that they're designed, the protocol. And so you have to, those of us who do a lot of this work have specific protocols set up at our institutions to look for peritoneal disease. And then assuming stable tumor markers, because obviously if it starts to go up, then we have to have another discussion. Even if we don't see anything on imaging, do we potentially take a look inside the abdomen surgically with what's called a diagnostic laparoscopy? We put a couple little incisions and we look in with a camera to look around to make sure that we don't see any disease. The question, though, of course, is how long. There are some institutions that stop at 5 years, similar again to the positive margins. And then at this institution, we're here at Emory, we choose to continue along. To not stop at 5 years, because there have been cases of late recurrences. The question, of course, is what is the overall recurrence rate? We have these small studies. It's somewhere with perforation, it's close, somewhere between 10 and 20%. With mucin outside, but no evidence of perforation, rather. It's somewhere around about 5 to 10%. So in that 5, closer to the 5 range. So if you have a rupture of appendix, it's somewhere in the 1 to 10 to 1 in 5 range. Again, the reason we have a range is this is just very rare, and so we don't have a lot of cases, which again is why we would suggest following closely for these types of scenarios. So that's that's the lamin. Before we go on to, I'm more than happy to take questions at this point if you want, or we can about lamins, or we can go on and then we can just take questions at the end. How do you guys want to do that, Adele?
Yeah, I mean, I'll leave it up to the group, and we do have some questions about signet ring, but you'll probably address those when you get to goblet cell. So I would say anyone that maybe does have a question about lamin, maybe put it in the chat, or
So why don't we keep going, and then there's a couple questions about adenocarcinoma before the chat, and so I'll answer that, and then we'll probably get through it. So, and then I'll look through the chat as well to answer the questions. Okay.
perfect. All right.
So the other thing, and then someone also asked a question about ctDNA, so I'll just quickly comment on that before we go to the chat. But so goblet cell adenocarcinoma or carcinoma is a relatively new, if you will, diagnosis. It's been around for a long time, but it was kind of called different things. It used to be called crypt cell carcinoma or ex-goblet carcinoids, or just a goblet carcinoid, and it was unclear exactly what it was, but it's becoming more and more clear. It's a weird type of tumor, and again, on the spectrum, if this is over here, you have your lamin, maybe a Hammond right here, and then you kind of come all the way over here, and you get your goblet cell carcinoid is about 3/4 of the way, and then adenocarcinoma, and then signet ring adenocarcinomas are the most what we call aggressive, if you will, types of appendix cancer, but there's different histologies. That's what they are. But goblet cells about that, maybe 3/4, 90. It's an interesting tumor. The appendix is really has we don't really know the function of the appendix, but we know that it has different types of cells within it. And as a result of having different types of cells, it can produce different types of cancers, because again, cells don't last forever. And so as cells turn over and try to grow and kind of rehabilitate themselves, they can make mistakes and eventually form an invasive cancer. So a carcinoid, you guys may have heard of those, actually the most common non-benign tumor of the appendix, are essentially our neuroendocrine or hormonal cells, similar to what we have in the pancreas and other places, that can grow and form a tumor. And they oftentimes will do in the hindgut, and that's just most common in the ileum, which is the end of the small bowel, and then the appendix is not uncommon. But this type of tumor is actually different. It has features of both cancers of the lining of the appendix, or an adenocarcinoma, and hormonal or neuroendocrine. So it's what we call a collision tumor, because it has features of more than one cancer, and it's very aggressive. There are different types, and there's grades are based. So you may have heard of a goblet cell carcinoma with signet ring differentiation. It gets very complex, and it's based on the pathology and the way the pathologist looks at the tumor under the microscope, and they assign them grades. The signet ring, because someone asked about this, the signet ring features in a goblet cell cancer just makes it a grade, depending on what percentage is present of the signet ring, will make it a higher grade, a poorly differentiated tumor. It is not, though, a signet ring tumor. It just means that it has features of that. A signet ring is just a feature under the microscope that they see. It usually suggests certain types of molecular changes within the tumor in terms of its ability to adhere to other tumors. They seem to be a little bit less cohesive, and so they spread easier when you have signet ring type tumors. But in this case, it just means that it's a poorly differentiated tumor. And I think that that's important, because it's not a signet ring cancer, which is a totally different type of cancer, even in appendix cancers. When you have a very high grade goblet cell cancer, they tend to spread early, because the appendix tends to rupture, and so it gets out through the wall of the appendix. and up to 70% will have metastatic disease at the time of diagnosis. Whereas a low-grade goblet cell carcinoma has very little risk of spread. And so this is another thing that's important is, depending on the grade will determine, that's what it will determine potentially your stage. So goblet cell carcinomas, you include grading in the stage because it really does matter. But the only way to know for sure is to do the surgery. So if it hasn't obviously spread, what will first happen, you'll get your appendectomy because, again, most people don't realize they have a cancer. They're getting appendix taken out for something else. They oftentimes will find this if it hasn't spread, and then you have to do something else. And this is important. At our institution, we found that especially the higher stage tumors have up to 73% lymph node involvement. Why is that important? Because it tells you what you have to do. And the answer is the first step, assuming that there's no obvious spread on CAT scan, on what we call clinical staging, when we look to make sure with imaging to make sure it hasn't gone anywhere, and the doctors that did the surgery didn't find any disease in the belly, the first step is a right hemicolectomy. After the right hemicolectomy, again, the HIPEC we'll talk about in a second. If you have lymph nodes involved, that's a stage 3, then we do give chemotherapy. And there have been several studies that have shown that these tumors are responsive to colon cancer type regimens, and it improves overall survival in patients who have lymph nodes that are positive. So we do have some data for this, and it's important. Now, the question, of course, is if it's already spread, so it's stage 4, it's gone beyond the appendix, what do we do? And I think it's beyond the scope of this discussion, but what we usually try to do is give some therapy up front, make sure we get a response. And if we can get a response and the disease is amenable to removal, meaning we can leave gut behind, because sometimes it's peppering the surface of all the bowel, and we can't, unfortunately, we have no way to remove all the bowel and allow people to live. But assuming that it's potentially an option, then we do the cytoreductive surgery in HIPEC. And obviously, the more disease you have, as with any, most of you have either had surgery or potentially going to have surgery, the amount of disease is really what determines recurrence rates, and the ability to get removal of all the disease is also very important, but again, beyond. So I think the key point is that if you have a localized tumor, we still do the right hemicolectomy, and then we give chemotherapy. And HIPECs are really reserved for patients that have had, stage 4 with peritoneal carcinomatosis or disease in the belly cavity, who've had stable disease or response to chemo, and have amenable disease, meaning we can get rid of the disease without removing too many critical structures in the belly cavity. So that's again, very basic, but just so people understand what it is. We get a lot of questions about ctDNA, so I don't have a slide about it, but I just wanted to mention it. This is ctDNA is circulating tumor DNA. It's becoming more and more common in the follow-up surveillance of colon cancer, and it's being studied in appendiceal cancer as well. There are a lot of abstracts and presentations about it at national meetings. It is not yet really in, shall we say, primetime use. We do have some data that show, there are multiple studies ongoing, including here at Emory. We've had a couple of studies for high-grade appendiceal cancers and ctDNA for surveillance in terms of recurrence risks and things like that. There is some data in the colon cancer that shows this isn't really, it's not circulating cancer cells. It's circulating kind of byproducts, if you will. And there are different ways to do it. You may have heard of liquid biopsies or things like that. But there are also something called Natera, the company that does Signatera, where they actually take the individual patient's tumor and kind of then check their blood to see whether there are any byproducts in their blood. But for high-grade appendix cancers, there may be some utility, and we're still trying to figure that out. There are some papers that are coming out to see whether or not it could potentially demonstrate the ctDNA, circulating tumor DNA, can potentially help us detect recurrences earlier. But that's really where we are right now with ctDNA. It's not a treatment protocol. It's really just a surveillance. It's a bit better than right now. CEA and CA125 and CA19-9, you may have heard of those, are really the only 3 tumor markers we have that are useful. ctDNA is probably something that's going to be a bit more helpful in terms of for higher grade tumors following. So that's that. So I wanted to answer these 3 because these were asked earlier. I think I already answered the middle one. And again, to say that it's not goblet cell with signet ring is just demonstrates the grade of the tumor. It's not a signet ring tumor per se. There's a different appendix cancer with signet rings, and signet ring tumors of the appendix are a totally different disease process. Those are adenocarcinomas or carcinomas of the, cancers of the lining of the appendix, and have a different prognosis. Treatment is similar because it's similar for all these, but it's a different discussion. Appendix cancers with signet ring features or signet cell tumors of the appendix overall have a better prognosis than colon cancers with signet rings, but they're still a very aggressive tumor. Let's go to the last one. So I think I answered this, but I just want to make sure it's clear. So a lamin, again, is not a cancer in and of itself. A lamin is just a polyp of the appendix. And as long as it stays isolated, kind of in its shell, if you will, within the appendix, you take it out, you're done. If it didn't rupture, again, don't have mucin or cells at the margin where they cut, you're done. You don't need any surveillance if you have a normal colonoscopy, of course, unrelated to the lamin. A mucinous adenocarcinoma is a type of invasive cancer of the appendix. That's all the way over on the other side. There are different types. The most common type of cancer of the appendix is a mucinous producing one, and it makes sense, right? Because the appendix is a piece of gut, and it has, at least at some point, although we don't really quite understand it now, at some point it had to kind of line, push things along, if you will, and so it had to lubricate the lining, and so they have mucin producing cells, and they don't last that long. They get to turn over just like any other cell in the gut, and so it can produce an invasive cancer that produces mucin. And so lamin is not a cancer. It can act like a cancer if it ruptures, meaning it can come back in the belly cavity as this what we used to call pseudomyxoma, but it's not in and of itself a cancer. It doesn't go to lymph nodes, which is why we don't need a right heavy-colectomy, right? It doesn't go to the liver, doesn't go to the lungs. Whereas mucinous true adenocarcinomas or invasive cancer of the appendix can metastasize or spread just like any other cancer of the gut. They go to lymph nodes, they go to the liver, the lungs, etc. And so we treat it a lot more aggressively with systemic chemotherapy, meaning IV, as opposed to a lamin, because it doesn't have a lot of cells, and they're not invasive cells. They don't really respond to chemotherapy, which is why surgery is the mainstay for lamin, whereas at least up front, for mucinous cancers or any appendiceal cancer, surgery, unless it's localized, is not the mainstay of therapy. Now, if you have an appendix cancer in a non-ruptured appendix, then you get surgery on. And if there's no disease elsewhere, that maybe you had appendicitis, they found a cancer, then the next step is to take out the right colon. But that's just to stage it, right? So we talk about staging it. We need the lymph nodes, we need the actual tumor, the lymph nodes, and then make sure there's nothing else in those. And so then the question is, what is the difference between pseudomyxoma peritonei and appendix cancer? So we've gone away from using pseudomyxoma as a term in the literature, at least. They still use it in the vernacular, in kind of the colloquially and within our presentations, etc. Pseudomyxoma is what used to be called jelly belly, right? It's when pseudomyxoma, you have a patient who comes in with a lot of disease and a lot of mucin all over. The problem with pseudomyxoma is it can be from different causes. It can be from ovarian cancer, it could be from colon cancer, it can be from appendix cancer, it can be from all these things. And so it got a little bit confusing as to what people were actually discussing. And so instead, the pathologist decided to, over time, it had different iterations, but it eventually became, at this point, we're calling it peritoneal carcinomatosis, which just means spread of cancer in the belly cavity. Can be low grade, grade 1, grade 2, or grade 3. So there's an intermediate grade and there's a high grade. The cause of the peritoneal carcinomatosis can come from anything. It can come from gastric cancer, it can come from ovarian cancer, from colon cancer, from appendix, from mesothelioma, from the gallbladder, from cholangiocarcinoma or bile duct cancers. But when we see cancer in the belly cavity, we now call it peritoneal carcinomatosis. So appendix cancer can cause peritoneal carcinomatosis, or we used to call pseudomyxoma, but it is not the same as it. Okay. I hope that clears that up. So I think that's the last slide. So I'm going to stop sharing and I'm going to start answering questions from the chat, if that's all right.
Absolutely.
So let me just make sure I don't do this. So I think Donna wrote the first question. So it's I've been diagnosed with that. Everyone can everyone see the chat? Yeah. So for those who I'm not so facile with Zoom, so I'll pretend that everyone else isn't as facile. So I'll just read the question just to make sure we're on the same page.
That's perfect.
So I've been diagnosed with adenocarcinoma in a mucinous background, including signet cells. Now I have mucin in my abdomen. I started chemo to stop development. Any comments? So the answer is, so again, just to kind of, I think what I'd like to do is just kind of hammer this home time and time again, because I think it's important. So the appendix cancer was what's called a mucinous adenocarcinoma. The cells that produce the mucin in the appendix of the lining formed an invasive cancer, got the ability to invade. And there are some signet rings, meaning that it's a more aggressive. Now, there's a difference between signet ring cancer and signet ring features, and it's very complex. But the point is, as long as it's not, they don't call it a signet ring cancer, it doesn't quite meet that criteria. But whenever we see signet rings, it just suggests that there's more, that the tumor potentially has the ability to spread more often. But we treat it the same way. And so I don't know whether you want to speak, Donna, or whatever, but the basic point is that you had a surgery, unfortunately found then in the belly cavity, and now they're giving you systemic chemotherapy or IV chemo. Generally speaking, assuming that you've had stable disease, and you should at least be evaluated by a specialist who performs this. Now, I wish that I could help everyone. I think this is a key point. We cannot, unfortunately, we cannot help everyone. Sometimes we can palliate, meaning even if we can't get rid of everything, we can be aggressive and do things. But each surgeon has their own perspective on what should and should not be done. So you want to meet with the surgeons, but sometimes you need to meet with someone else. And it doesn't mean that the surgeons, just because they say no, means that they don't feel that you shouldn't get surgery. It's just they don't think that they can help you, and they want, because again, we are trying to make sure that you get the best care possible. And sometimes the best care is staying on IV chemo and not going to surgery. But sometimes, especially if you have a lot of fluid in your belly, even if we can't get rid of the cancer, sometimes we still do something called a HIPEC, which is when we put chemo inside the belly cavity, because it can control ascites in certain circumstances. And there's a new technology that is getting a little bit more airplay in the United States called PIPEC, which is aerosolized or laparoscopic type. Again, it just has a little higher pressure, so it can go through thicker tumor a little bit. The problem with HIPEC is that it doesn't penetrate all that deep into tissue. So you really have to get rid of all the tissue, the cancer tissue first, before you can do it, because it only penetrates about 3 to 4 millimeters into the tissue. So if we can't get rid of all the tissue down to about 2.5 millimeters at most, then a HIPEC will not be effective in and of itself. HIPEC can penetrate a lot more, in some studies up to 1 centimeter. And so we are doing some randomized trials in the United States right now to try to see if that is something that will be effective. But it's not FDA approved yet in the United States. It's just getting there. And so there aren't many centers that are doing it. And you have to get specific training from people essentially in Europe to be able to do it in the United States. And so more and more centers are doing that. We're hoping to open a trial here at Emory within the next 6 months, but we have to get approval of it first. So it's coming. It's available in certain centers right now on trial, but that may be something else that can help with mucin in the belly, even if it cannot be removed. At least control the mucin, which can be very uncomfortable and can help with things. Now, if you've had a lot of surgery, then that may not work too well because you have to be able to safely get into the abdomen to be able to do it. And if you've had a lot of surgery in the past, sometimes it can be very dangerous to operate. So, but I think, if you haven't met with a surgeon who does these surgeries yet, I think it makes sense to review everything. Now sometimes, so it looks like, sorry, there's another, just going down the message. And now Hammond, just so people understand, there's a lamin, which is low-grade appendiceal mucinous neoplasm. Then there's a Hammond. Hammond is a high-grade appendiceal mucinous neoplasm. Sometimes this can have a component, a cell or two, that is more invasive and can act like a true cancer, even though the main part of the appendix is actually not a cancer. Hammond is just it's kind of working its way there, but it's not yet invasive. But we can't look at individual cells under the microscope. If we happen to, even if we slice it up really, really small, we can't see that. So sometimes on these Hammonds, there are actually lymph nodes involved. And so we oftentimes will still suggest, if not in patients who've had metastatic disease, but patients who haven't yet, to do a right hemicolectomy to make sure that there are no lymph nodes involved. It's a different discussion. However, again, I think that Donna, you should meet with someone if you haven't. Paul, this is so you had low-grade mucinous adenocarcinoma. It was, if you don't mind, it's a little hard to say what you mean. Was that of your appendix, or did you have disease in the belly cavity as well?
Both. So mine was what we thought was a hernia. It turned out to be a tumor, right hemicolectomy, and then a consult with a specialist after the first surgery. And then it was low-grade mucinous adenocarcinoma. And the surgeon was very, very positive about positive effects after the HIPEC and cytoreductive. So my question was, if it's low-grade mucinous adenocarcinoma versus Hammond, was mine the best of what could have been the worst results?
So a Hammond is not a cancer in and of itself. A low-grade appendiceal mucin, depending on it's a great question. So I sometimes think that the pathologists change their diagnoses every 6 to 12 months to confuse everyone. But in this case, assuming that what they took out was, when they say low grade, they say low grade peritoneal carcinomatosis, low grade. Then what that means is that it probably came when they took out the appendix, is really what they're looking at. If on the appendix they saw a kind of a mucinous adenocarcinoma, that's a true cancer, and it can come back. However, if the surgeon was able to remove it all, and you had a low volume of disease, and then they did the HIPEC, that's a very good chance that it won't return. Obviously, it depends on the amount of disease, whether they could get it all out, etc. As with anything, kind of I mentioned, if you notice, a lot of these things tend to come back within the first 2 to 3 years. And that's some connection between the body, the chemo, the immune system, and the cancer itself. And so we usually do more aggressive surveillance the first couple years, 2 to 3 years, and then we kind of start spreading it out again. So I suspect that your surgeon is doing, if it just had this, then probably be getting relatively often CT scans and tumor markers and things like that.
Mine was 3 years ago, and I've graduated to 1 year between service calls.
There you go. And that's about. And then the question, of course, still, and we're working on this now with the Chicago guidelines, is how long do we have to follow you? Currently, the guidelines are indefinitely. But do we really need to do that, or do we have enough data yet to know? And so that's one of the things that people are saying. So Debbie, you said that. No problem, sir. And by the way, Don, I'm more than happy to talk if you'd like. Send me an email, or you can talk out here if you want everyone to talk as well, whatever you prefer. My papers say mucinous adenocarcinoma of the appendix grade 2. So there are 3 grades. So when we talk about peritoneal carcinomatosis, we talk about grade 1, which is really usually what we used to call DPAM. If people have heard of that, the diffuse peritoneal adenomycinosis, which is, majority of the stuff we find in the belly cavity is mucin, but an occasional cell here and there. There's a grade 2, which is what we call now kind of intermediate grade, but is a true cancer. And then a grade 3, which is more poorly differentiated, maybe has signet ring features, etc. But a grade 2 is usually kind of what we call the bland, if you will, adenocarcinomas, or the more kind of common adenocarcinomas. Could be mucinous, may not be mucinous, but it's a kind of a standard cancer of the appendix. If it's in the belly cavity, those are usually people that we talk about doing a HIPEC on for any of those grades, as long as there's not significant disease. There's a question for the higher grade cancers as to how much is too much in terms of disease. And the reason is that, when we do a big surgery on patients, your immune system gets really knocked down. Your immune system can only do certain things. You need to heal that surgery, right? So I can go and do a really huge operation on a patient who has a lot of disease with with a grade 3, let's say, and we take it all out if it's possible, assuming that there'll be an adequate bowel left, etc. But in order to heal, the immune system goes into a pro-inflammatory state. That's the first stage of healing. It's a lot of inflammation, and if there's any residual tumor in there, then the cancer loves that, because in order to grow, the cancer needs to make new blood vessels. It needs to do all these things, and all the inflammation that the immune system does as part of the healing it basically revs up the cancer growth as well. So if you have a lot of disease in a patient with a bad cancer, we're still trying to figure out what that line is, and that's part of what we were trying to do at a collective kind of national level, to try to get studies together to determine, is there a certain point where we shouldn't be operating, because in the end we're actually going to hurt patients and not help them. And so that's low grade. As long as we can leave enough gut and organs, we operate, as many of you will know. Higher grade is a much more complex question, and it's very difficult to answer sometimes. So does that answer your question, Debbie? Okay, but the next.
Thank you.
You're welcome. But we generally, but for grade 2, again, if it's in the abdominal cavity, we generally do, assuming that there's a reasonable, depending on the evaluation by the surgeon, we oftentimes will do HIPECs even for grade 3. Just depends on the amount of disease and where it's located. And so that's why for all these cancers, it's always important to meet with a surgeon, right, who does this. You don't want to meet with the local surgeon who's seen one of these cases in his or her lifetime, which is not uncommon, by the way. Where I trained at the Brigham, and I remember when we had a patient who came in, and the surgeon, who was a very well-known cancer surgeon, had taken care of 5 of the patients in his entire life, because it's not what he did, right? And so and you know, let alone I you know, trained at some of the outlying community hospitals, and they oftentimes had only seen one or two of the cases in their entire careers, and they've been operating for 20 or 30 years. It's because it's not common, right? We don't see these that often. That's why you want to go to a high volume center to see these. Signet ring adenocarcinomas can produce mucin, depending on how well differentiated they are, meaning how much they look. So that's another, I think, important point is what does differentiation mean? Because it's a, you often see it on a pathology report, but heck, it means nothing unless you understand what it means. So when a pathologist looks at a slide, they kind of have to name what's going on the slide. And so they try to determine where the tumor is coming from, but they can't do that. You know, all they can say is, Josh Weiner gave me this. He says it's the appendix. So then they can look at it and say, well, okay, he says it's the appendix. I trust Josh Weiner because he does a lot of appendectomies. Does it look like the appendix or not underneath the microscope? And if it looks like it's the cancer and it looks like it's coming from an organ that produces glands, and it has well-formed glands, it kind of looks very, very kind of normal, then that's called well-differentiated. So it can be an appendix cancer, it's invasive, but it looks like it's coming from the appendix or from a GI organ. Obviously, they can't tell the appendix of the fact it took it from. But let's say they get, on the other hand, a lot of disorganization. They can't actually see any glands. They see a lot of invasion, but they can't tell where it's coming from or that it was even a GI organ to begin with. And that's called poorly differentiated, because they can't, unless they knew that I told them, hey, it's coming from the appendix, they can't tell that. Okay, and so that's called poorly differentiated. If it's not forming glands, it's not cohesive, it doesn't look like it looks like it's trying to kind of get out of, get out of the organ that it started in, then they usually call that poorly differentiated. And then there's in between called moderately differentiated. It sort of looks like it's forming glands, but not sure exactly. And obviously it's a lot more complex than that, but that's, I think, the basics. So, and this is important. So this is a good question Sylvia asked. Lamin T3 appendix cancer. So key point, lamin is not in cancer. Okay. So, and this is a common misconception, especially now that so when we talk about T stage, that's what T stage is. How does a tumor go through, it's different depths of invasion. Okay, but lamins don't invade, Dr. Weiner. So how can it have a T stage? Well, recently the pathologist in the American, we call it the TNM staging, was started to be applied to appendix tumors, including lamin. And so, but these tumors all tend to have mucin in the wall, and that's normal. And so they're almost always T3. If it's gone through the wall, that's where we're concerned that it can come back. As long as the mucin is within the wall, doesn't go outside, there's no mucin on the surface, on what we call the serosa, which is the surface of the appendix, and it's taken out completely, then it's not a cancer and it's not going to come back. On the other hand, if there's a positive margin, kind of went through this, if there's a positive margin, meaning there's mucin or cells at the margin where they cut, and it's actually described by the pathologist. They'll say, yeah, there were neoplastic cells is what they call it, or tumor cells at the cut edge, or mucin, or there's stuff on the surface, again, the serosa, or there's a rupture or perforation. Those are the ones that can come back and need to be watched. Again, as I kind of showed you earlier, it's a question of how long we watch them and how aggressively, but patients with those types of tumors should be watched. But again, I think it's a key point. A lamin is just a polyp. It's not a cancer. Unfortunately, if it's ruptured, it can come back and act like a cancer, meaning it can spread into the belly cavity, right? That's the most common cause of peritoneal carcinomatosis from appendix tumors. But again, it doesn't go to the lymph nodes, doesn't go to the the liver, the lungs, etc. So it's not an invasive cancer, but it can come back. So as long as it didn't rupture, Sylvia, and none of those things were on the pathology report, you're good. If there's any concerns, you can send me the pathology report. I can at least look at it. But again, generally speaking, we usually confirm, unless it was at a high volume institution, we generally confirm. Now, the problem with lamins, as you would guess, there's a lot of essentially snot inside these things. So when they cut it, guess what happens? It comes out, right? And so what the pathologist has to determine and make sure that what they're seeing is actually stuff that didn't come out during the processing of the specimen, because that could change. That could take someone who never needs any follow-up to someone that then gets at least 5 years, if not more, follow-up, right? And it's stressful for the patient. So you have to determine that. Sometimes, unfortunately, we can't tell. Sometimes the thing got ruptured in the bag that was removed, so no risk to the patient, but we can't tell whether it had actually ruptured or not because of the processing. And then we have to be careful and we have to follow. So I have several patients who, unfortunately, during the processing outside places, unfortunately, they couldn't tell whether it was ruptured or not. And so we follow, because we'd rather be careful, right? And catch it if it were to come back, than not be careful and miss a recurrence that we could easily take care of if, God forbid, it did return. So Mark asks a good question. So let's say I had a cytoreductive surgery and a HIPEC, and it's obviously patient dependent here, so it's a little bit difficult. But if it's not successful, can debulking help to extend lifespan or potentially palliate? So I think it depends on the amount of disease and the ability to deal with the complication. Meaning, if you've had a HIPEC and they didn't get rid of all the disease to begin with, there are a lot of institutions that wouldn't have done the HIPEC to begin with, unless you had a lot of ascites, which is fluid in the belly, and then they were using it to control the ascites. Because again, as I explained, it doesn't go into nooks and crannies of tumor. If the tumor is this thick, it's not going to take care of it. So oftentimes we would debulk as much as we could, but unless you had a lot of fluid at the time, we wouldn't do the HIPEC. If they did a HIPEC and it controlled your ascites for a bit, but now the tumor is spreading again, if they couldn't debulk all the tumor to begin with, they're unlikely to be able to debulk all the tumor now, right? If they couldn't do it at the best case scenario, which was the first time, the ability to then do it afterwards is unlikely. So the question becomes, is it worthwhile for the patient, right? Because that's what it is. Is it worthwhile for the patient to deal with complications? If you're dealing with, for example, a bowel blockage, and there's, but you can bypass that potentially. And sometimes we do go in to go around the blockage. Oftentimes we can't do anything, but sometimes it's at least worthwhile looking. But if the surgeons who are trained to do this and are aggressive couldn't do the HIPEC to begin with because of, for example, most common, a lot of reasons is that, number one, there wasn't enough bowel left. There's a lot of blood vessel involvement, or there's a lot of disease around the liver structures called the porta hepatis, which is where the bile ducts go into the liver. We can't cut those out. It would require Whipple surgery, liver transplant. We can't do that in the setting of metastatic disease. And then the answer is those aren't going to change over time unless you've gone on a clinical trial and that those problems have disappeared. And there are some patients who we've seen who had issues like that, had to get stents or even tubes into their liver to drain the bile ducts, who've gone on therapy and have had miraculous results. And then those patients, some patients have gotten to HIPEC for a second HIPEC, but it's an individual case and evaluation by the surgeon and by the patient determined. But oftentimes it's more palliation or comfort, if you will, than curative or even extending life. So it just depends. Good question. So Tara, can PMP occur in all subtypes of appendix cancer? Again, theoretically, yeah. I mean, it's a pseudomyxoma. Again, let's use the term, if you will, peritoneal carcinomatosis, if you don't mind. You can get spread into the belly cavity. There's no reason that it would occur necessarily, meaning if it didn't rupture and let's say you had, run-of-the-mill appendix cancer. Unfortunately, you had an appendectomy because you had appendicitis. They found a cancer in it, and they took it out. They did the right hemicolectomy, and you got therapy if necessary or on surveillance. As long as it didn't rupture, there's a small risk, but it's no higher risk than, let's say, for example, colon cancer going in, which is very low risk. The higher the T stage, or the thicker the tumor, the further it goes through the wall of the appendix, the higher the risk of it coming back in the belly cavity, because theoretically cells could have escaped. But if it didn't rupture, it was a T3 or T2, something like that, and you just had a right hemicolectomy, yes, it can come back, and that's part of the reason we do surveillance. But we're also looking to make sure it doesn't come back in the liver or the lungs or things like that. But any cancer could do that. And should we be moving away? Honestly, it's really it's a technical term that we use in literature and stuff like that. And I think that we as institutional folks have not yet completely embraced it. So it's hard to convince everyone else to do it. If you look at, even nowadays, if you look at papers, there are still centers that are not the high volume ones, because our pathologists won't let us. But there are still some centers that are using pseudomyxoma peritonei in their papers. So, but I think it's more correct than pseudomyxoma. Pseudomyxoma is a very specific type. It's that a lot of mucin with tumor disease, usually low-grade disease. It can come from various types, but I think peritoneal carcinomatosis is more of a kind of an overall catch term for disease in the belly cavity. So Tammy asked a question about surgeons had to leave cancer in the portal vein. That's essentially what I was just talking about, Tammy, that if there's disease on the portal vein, we can't cut out the portal vein in the lymph nodes. We can sometimes get the lymph nodes around it, but we can't cut out the portal vein or the bile ducts in the setting of significant disease elsewhere. We are usually able to get the tumor, if they did a complete cytoreduction and gave you a HIPEC, what that means is they were able to get the tumor down to very minimal thickness, what we call a completeness of cytoreductive score of 1. So less than 2.5 millimeters of disease, which theoretically the HIPEC should at least control and potentially even kill it, which is why we do it. And systemic therapy will also, so we usually in that setting would want to give some chemotherapy afterwards, is usually what happens. And then we follow. But in terms of the ability to remove it, the answer is we rely on the actual chemo in the OR and or systemic chemo to control or get rid of it. And your body also tends to do it. So we've done studies in the past that have looked at the actual changes in the cancer. We've left cancer intentionally in the belly when we do the HIPEC and then take it out afterwards, so it's not there anymore. But to see what happens, and there are significant changes under the microscope and genetically in tumors that have undergone the chemotherapy and the heat. And so we do see continued cell death after the HIPEC, which kind of makes sense, right? Now, does the HIPEC actually work? That, as you know, there's probably this group more than anyone else, there are a lot of studies going on in the world to look at that, to determine, is it just the cytoreduction, meaning the removal of the cancer, or is it the HIPEC, or is it both that's leading to improved survival? And that's a question that we're trying to answer right now in various randomized trials. More so in Europe. It's hard to get these types of trials going in the United States, but we're working on it in various cooperative groups. So Tara asked, what research clinical trials are we doing at Emory? We're doing mostly chemotherapy, systemic chemotherapy trials and immunotherapy trials. We do have several preclinical trials with various markers and whatnot, translational, if you will, going, to try to figure out if we can figure out a way to inject various substances into the abdominal cavity to try to get these things to to die without having to do major surgery and things like that, and also to identify residual tumor fluoroscopically in the OR and things like that. In terms of, but most of our trials right now are phase 1 trials for chemotherapy or new molecular types of therapy for patients that are not surgical candidates. We do have, in terms of surgical trials for HIPEC, we're mostly doing registry stuff right now as we're trying to but we do have an ovarian cancer trial that's opening up at Midtown. I'm not sure when that's going to be opening up for HIPEC, but that's going to be opening up soon under the gynecologic oncology auspices. And we're going to try to get, like I said, if we can work through the various hurdles, potentially a HIPEC trial going within the next 6 to 12 months as well.
Dr. Weiner,
Yeah.
on this next question, and I don't know how long you can stay.
I can stay as long as you guys want me to.
Okay, great. We have a few more questions. This
Yeah.
next one, if you will scroll down just a little bit, I think the submitter kind of hit the publish button too soon. If you'll go
Sure.
down to Carrie Nunes a little bit through about 3 or 4.
All right. Yeah.
Dialogue.
Okay, got it. So T4 lamin growing up into the cecum and having issues. Yeah. So the answer is it's possible that they could potentially have misdiagnosed it. This gets also to something else that I was intentionally staying away from, but I guess we'll mention it. Sometimes when these cancers, so let's say a patient has a lamin, ruptures, we find disease, it's low grade, we do a CRS HIPEC, and it comes back early, within 6 months. You biopsy and it's actually invasive cancer now. And clearly something is going on here, right? Because, we took out a lot of specimens, we sent it all to pathologists, it's all this low grade tumor, yet when it returns, it comes back as a high grade tumor. And it turns out that although the lamins don't have the ability, there are individual cells that we, as I think I mentioned, we can't see individual cells. And sometimes, in very rare circumstances, this is not a common occurrence, that when although it's a grade 1 an initial presentation, if and when it recurs, it can recur as a higher grade tumor. So it's possible that, Carrie, you had a lamin and they took it out and they actually looked at it and it's correct, but it came back as something more aggressive, or there was something more aggressive to begin with in addition to it, and there's what we call discordance, meaning it's not the same from what they removed and what's actually causing your problems. Usually when we see elevation in liver functions, if again, it's hard to say without looking at your case and including imaging and things like that, but sometimes it can be that there's something outside. I think one of the patients earlier had mentioned that they couldn't get their surgery because of tumor on the portal vein. Well, it doesn't just go on the portal vein, it usually encases the entire area, which includes the bile ducts. And imaging is really good, but it does have its limitations. It can't see plaque-like disease or paper-like, like flat disease. There's really no way to see that on imaging. So if you have nodules elsewhere, there's a potential at least that you may have disease around your porta that's kind of constricting the bile ducts. But without looking at your imaging and without, kind of going through things, it's hard to tell. And I think, it sounds like you should meet with a nutritionist, and you may need to go on IV nutrition and kind of figure this out, because clearly if you can't gain weight and you're having issues, even if it turns out to be something that is something that's potentially a surgical, no one can operate if you're that debilitated, because we would hurt you, not help you. So that's usually what we suggest. I know that's a quick answer, but there are HIPEC specialists in Australia, and so I would reach out to one of the larger centers, and they're I've met a couple of them. It's been a while at some of the meetings, so I know they exist and they're good people. Again, a couple of times I met them. Dan says that his HIPEC was aborted due to cancer in the small bowel. I'm not quite sure. I guess it's never gotten worse, maybe after 3 years on a CT scan. They've always been about the same. So
I guess my question, doctor, was, is that unusual? The HIPEC was aborted. That was over 3 years ago, but the cancer in the small bowel has still never appeared on a CAT scan, and I get every 3 months. I thought it was kind of, not that I would change. I'm thankful because I've been on chemo every 2 weeks, and I've had a wonderful 3 years, except for being exhausted. And but is that unusual that it wouldn't show up?
So it depends on the cancer, of course, type. I assume is this appendix cancer?
Yes. Yeah.
So I'm guessing, again, I'm inferring certain things here, Dan. You have to forgive me for that.
No, that's okay.
But the assumption is again, just like I just mentioned to Carrie, what usually that means is that the disease was very plaque-like, and it was thick, or thin, but thick enough to constrict the bowel to the extent that they could not remove, because you had to remove too much bowel. So there's different. The bowel kind of looks like a tube, right?
Yes.
But it also has all the blood vessels underneath. It's called the mesentery. That's the blood supply. Mm-hmm. Usually cancer, so low-grade appendix cancer tends to kind of set up shop on the peritoneum of the mesentery. That's easily resectable. The problem becomes is if the higher grade tumors, which sounds like you have because you're getting chemo, is that they can set up shop on what's called the serosa as well. Obviously, the lower grade can as well, but it usually just wipes off. But the higher grade sets up shop, and they make implants. And the CT scans and MRIs are not good. They can't see 1 millimeter tumors. And they just can't. They're below the resolution. They're pretty good, but they're not that good, especially if they're flat. They're not like a mass. Mm-hmm. So they can see things 1 millimeter, 2 millimeters, but it has to have a little bit of thickness to it. So what oftentimes when they say that they aborted is they often meant that there was too much bowel involvement with those like miliary or kind of like little polka dot tumors, and they couldn't take out all the bowel. Mm-hmm. And because you'd be left without any small bowel, and that's not compatible with life. And so they probably, I'm guessing, again, without looking at your chart, of course, I could be but that sounds most likely what happened. And so, and as long as the chemo is working, you're not going to produce any large tumors, which is great. At some, the hope would be that the chemo will continue working forever, but obviously you can't predict it. Eventually, most of the time, the cancer does outwit the chemo, but the hope would be that it won't. Right. But we can't predict that. And everyone's interaction between the cancer, the chemo, the immune system, because it's all important, is different. And each cancer, their tumor profile, the genetics of the cancer is different. And so that's why it's very important to have an oncologist for you who is very good at kind of sequencing the various types of chemo to make sure that it stays at bay as long as possible.
Well, I'm the happiest guy in the world when my CAT scan comes back and it says unremarkable, spleen unremarkable, liver unremarkable. I'm a happy camper, and it's been that way for 3 years so far. So, and
may it continue.
Yes, thank you so much. That answered my question. Thank you.
You're welcome.
Now,
so Connie, I think Connie.
Dr. Weiner, I wanted to just say that next question is mine about Lammin. And then if you scroll down to the very last question, after you read mine, look at Lindsay Barat's, because I think we're kind of asking about something.
Same question. Yeah.
Yeah.
So So lamin is something, it tells you about where it started. It doesn't tell you about what they found. So peritoneal carcinomatosis grade 1 is usually, because you may see that on your pathology report, is usually comes from a lamin, okay? Meaning that it was a lamin, it ruptured, you got mucin in the belly cavity, maybe a couple neoplastic cells or epithelial cells, lining cells are in there also, but it's mostly mucin. And that's called peritoneal carcinomatosis. And it usually means that there was a microperforation, meaning even if they took it out and there was no obvious rupture, at some point it probably ruptured and then sealed itself off. But enough cells got out that it started to set up shop elsewhere. Okay. And because lamins are essentially, they're living tumors, it sealed up. And just like diverticulitis, you may have heard of diverticulitis, right? Those are little diverticulosis or little outpouchings of the colon, but they can rupture and then seal up, right? So presumably the tumor, although that's a benign disease process, presumably here what happened was the tumor kind of got under pressure, popped a little bit, sent stuff out, and then sealed itself up before it and didn't continue to lose, assuming they took it out and there was no obvious rupture. Also, if it dissects, the mucin dissects through the wall and gets out, that's another way that cells can spread, even without an obvious rupture, although by definition it had to have had that microperforation, the microscopic perforation. So the reality is it doesn't, whether it ruptured or it got out, in the end, the end stage is still the same thing, which is disease in the belly cavity. And so we have to deal with it. And the hope would be in a low grade tumor like a lamin that we'd have a good response. In the majority of people, we can remove everything and get it out. Now, unfortunately, if it stays there long enough, it can get like concrete, meaning so if someone has been not realizing they had it, but been dealing with it years and years and years and years and years, and not realizing they had a rupture and had ascites, this mucin can become really hard. And even though it's low grade, unfortunately, sometimes it's stuck around those important structures and we just can't chip it off. And so there are more, I think, Adele, you were talking about that, right? So there are not yet ready for prime time trials looking at mucolytics or things that potentially dissolve mucin to see whether or not in cases like that, we could potentially get to a point where we could downstage to the point where we can do surgery. But, in the trials that we're looking at with these mucolytics, there are a lot of complications. Patients are getting septic, they're having ruptures because it's been there for a long time. So it's eating away into things. And so it's not free. And so they're very small trials and they're still very early stages. So hard to say, but there are trials ongoing in the country and elsewhere looking at these mucolytics, like the bromocysteine, various mucolytics. I'm not going to go into the various types because there are several different ones. So let me just make sure I got Chicago guidelines. When will they be updated? Dr. Taraga is working huge effort. So we are currently this is a national thing. We've done multiple meetings. They're going through all the data right now to make sure that we get to, and then it's gonna come out to the consensus to the group, and then it will be published. But these, they have a timeline, but what that timeline is not. It's up to the editors of the journal to determine. So I'm not privy to that information. I just know that we're working on it hard because I'm working on it hard. So the hope would be within the next year. I know for sure. But again, remember though, consensus guidelines, although important, are not the end of the story, right? Consensus guidelines are the best information we have now based on a really skilled group of individuals who are working really hard to give the best information, but they change, which is why, for example, National Comprehensive Cancer Network, the NCCN guidelines change every 1 to 3 years as more and more information comes out. And the thought would be that obviously this would be a similar process, that we would be able to update it so that we can get these out to the various societies and whatnot, so that we can make sure that as best as we know, we're trying to be state of art, standard of care is at a certain level. But it's a long process. It will get there. But exact timing, that's up to Dr. Taraga, who's spearheading the effort, and the hope would be within the year, I believe. So how do we keep cancer cells from growing besides chemo? It's a great question. There are a lot of small studies out there for homeopathy and things like that, such as antioxidants, things like that. The answer is I'm not a nutritionist, so I don't know enough about the data, but things basic, but I do periodically read the literature just to see what new things are kind of coming up. I think, as long as you're not on any major blood thinners, a lot of the various things that we do, fish oil, things like that, have blood thinning capacity, and so they can cause bleeding, especially if patients are already on blood thinners. You have to be a little careful with that. But antioxidants in general, fish oils, all those things tend to decrease inflammation. Things like berries, etc., decreasing red meat consumption, things with high nitrites, like when we talk about grilling, things that if you kind of are a char person, probably not a good idea, because that increases the nitrates in the food. Things like lunch meats, decreasing all that stuff, and then processed foods in general with a lot of sugar and things like that. It does increase the overall inflammatory response in general in the body. We know that. Does it really, if you cut it all out, does it decrease the cancer recurrence rates? I don't think that we have enough data for that to say that yet. So what I always tell my patients is those are, if you like smoothies, that's the things, berries are a good thing. They do have, glycemic index is very low, and they have high antioxidant content. But can I go beyond that? I don't think that we have the data yet. Maybe eventually. Paula, so diagnosed mucositis carcinoma of the appendix in June. What is that? So that's congratulations. So it's been 7 years. And then CRS HIPEC in January. Okay, so you probably had chemo and then surgery, and you had a CC0, so got everything out. Thin little space behind the liver. A little more chemo, and then 5U by pump every 2 weeks, and I'm a lifer. Feel good, and I'm glad to be around such aggressive type, intend to continue. So Paula, the answer is, if you're not having any side effects, but I don't know that we have any data for continued 5FU. But if it's working, I think if you and your oncologist are both comfortable with it, then that's reasonable. Just recognize that I don't, that no one can say that there are data that suggests that it improves survival. But I think a lot of what we do once we've had a bad cancer are also important up here just as much as down here. And if you're not having any side effects, and if 5FU is relatively benign for chemo, and your oncologist and you are comfortable with it, that's okay. Do we have data for it? I can't say that we do. So, I think the key point is that you've had no recurrence in quite some time, which is lovely. So beyond that, I think we'll go with as long as you guys are comfortable with it, then keep going. But recognize there are no data. I don't know of any data for it. And we've had many conversations with this in our institution is how long do you continue chemo after the complete cytoreduction, or do you give any chemo at all? And it's not an easy question, both from a emotional, physiologic, and actual in chemo interaction perspective. So why can't the term cure be used for laminin even after 10 or more years? So again, I think we have to make sure that we're talking about the same thing. Are we talking about peritoneal carcinomatosis secondary to lamin? Or are we talking about a lamin that has been removed, in which case, actually, you can say if it hasn't ruptured and it's been removed, you're cured without doing anything else at the time of surgery. If it's ruptured and you had a CRS HIPEC, we have had some, if you look at Sugar Baker's data, we looked at 20 years, there are some late recurrences, and in fact, I think we've all known people who've had recurrences 13, 14 years afterwards. It's extremely rare, I think, is the key point. So, usually, again, most recurrences occur within the first 2 to 3 years. I think, a significant number, and then it tails off after that. And that's why you see when you look at these papers, which most of us have done, if you look at series, the survival curves, thank God, they stay up here, right? After, they don't go down after, usually after 5 to 7 years. But you can get late recurrences. And so although we may see it coming up in consensus guidelines, maybe we should stop at 10 years. I totally understand, patients that say, you know what, I'm okay with once a year MRIs. I want to make sure that I don't miss anything. As long as insurance doesn't make it a big deal, because at a certain point, that's a danger, if you will, with consensus guidelines, is that sometimes, but in general, there are guidelines at the insurance companies, because, in the end, they want to make sure that they're not spending money when it doesn't need to be spent, right? Because if it's not going to help people, they don't want to do it. That they then kind of latch on to those guidelines and say, well, your society says that you can stop at 10 years. Even if a patient desires to keep moving, again, we're not saying 10 years. I'm just giving that as an example. So I think, that's why we're doing really kind of want to take our time to make sure that we review all the data before we publish any consensus guidelines. If you look at 2018, we don't put any endpoint on it. There was a reason for that. Jose, is there criteria? Does that help, Roberta? I'm not sure if that answered your question. Yeah. Okay. Is there criteria to be considered on appendix an appendix number surgeries training? So theoretically, the Society of Surgical Oncology, up until 10 years ago, approved certain fellowships, and it required certain things. 10 years ago, the American Board of Surgery developed complex surgical oncology, complex general surgery and surgical oncology fellowship that actually is now a board certification. So theoretically, if you are one of these board certified physicians, or you did a Society of Surgical Oncology accredited fellowship prior to that, then that included peritoneal surface malignancies, which with pretty much all the Society of Surgical Oncology fellowships did, and now as a requirement, you have to do a certain number of cases to be fellowship trained. That would make you, quote unquote, a specialist. Obviously, not every program is equivalent, right? Because some programs are going to see more of this, some maybe more peritoneal disease, some programs are going to see more maybe liver disease, some people are going to say more pancreas disease. But you're certainly required to see a baseline number in order to be board certified. But do we have specialists who didn't do that, who are still putting themselves out there as quote unquote HIPEC surgeons? The answer is yes. And we see general surgeons, colorectal surgeons, etc. So the answer is you have to look at the individual, unfortunately, and see, and ask them. There's nothing wrong with asking, well, where did you train? It says here you're a colorectal surgeon. Where did you train to do HIPEC? And the answer is I went to, Europe and did a week course, and then I came back and put, well, okay, that's fine. Okay, but how many have you done then? Right? So you want to ask. And how many do a year? A high volume HIPEC surgeon is, we try to, just like anything else, there are volumes that tend to improve both patient selection, knowledge of the disease process, of course, and outcomes. Why? Because if you do more of something in general, whether it's gallbladder surgery or hernia surgery or appendix surgery, or in this case, peritoneal surgery, you get better at it. And so you want to have someone who's done a lot of these cases. A high volume surgeon for this type of disease, been described at around 20 cases a year. It's considered a high volume surgeon. But in most fellowships, if you go to a high volume center, the fellows who come out will do more than 100 cases or more, because you're working with multiple surgeons, right, who are high volume surgeons. And so they're usually well trained, but there are multiple papers out there that look at kind of the training, the curve, if you will, until you become comfortable doing these types of surgeries. The HIPEC itself is just the heated intraperitoneal chemo is only 90 minutes out of the entire operation. The actual difficult part of the operation, the one where you need experience and you need to be able to do, and that's why you kind of have to be trained to do it, is the cytoreductive portion of the surgery. If you're a colorectal surgeon and you don't have access to a hepatobiliary surgeon, then you don't know how to mobilize the liver. You don't know how to deal with the porta hepatis, where there's disease that often is sitting around the bile ducts and stuff like that. You don't know how to take out a spleen because that's not what you were trained to do, except when you're in general surgery. Just like I don't know how to deal with inflammatory bowel disease because it's not what I do, and I shouldn't be doing it, right? Unless it's an emergency and someone needs surgery and I'm taking general surgery call. And it's the same thing with this type of disease. We want to make sure that the specialists who are doing it have done a lot of it. So you're right, Connie. A lot of people are afraid to ask their surgeon, but you should. And that's what it comes down to. Remember, this is your life. And not only that, I think I want to put it out there as something that's important. Not only should you ask your surgeon, how often do they do the surgery? How many a year? Again, because these things tend to come like anything else. As a surgical oncologist, I do many things. It's not just HIPECs, right? I do many HIPECs a year, well over the 20. But that's not the only thing I do. I also remove sarcomas. I do gastric cancer cases and things like that, right? Because I do other things, colorectal cancers, etc. And so I think that's reasonable to ask. But you should also. There's nothing wrong with getting a second opinion, meaning, you come and see Josh Weiner, and Josh Weiner, I look at your stuff and I say, I just don't think I can help you. Go get another opinion. That's okay. You should not assume that I'm the end all be all, because every surgeon in the end has to look at your case and do what he or she feels is right for you. And that may not be surgery, or it may be surgery, or, but we're not always correct. Meaning I'm not God. I don't pretend to be. I was given a certain set of skills, right? Just like we all are. And I try to use them to help patients. But sometimes I'm wrong. I may say, you know what? I don't think we can do this. Now, if I tell you can't do it and we look through it and you understand why and you agree, that's okay. Does that make sense?
Yes.
But I always think it's good to get a second opinion. And sometimes the second opinion will agree, and sometimes the second opinion will disagree. And sometimes they disagree and go in and realize they can't do it. And so that's why if you're getting a second opinion, what you also don't want to do is you don't want to go to someone who does not as many, right? So oftentimes oftentimes what happens is I'll have a patient who's come from Dr. Levine, who wants a closer surgeon, but Dr. Levine has offered that person surgery. So they're not really looking for a second opinion. They just don't want to travel and they have someone here. That's not really a second opinion, right? That's, you already had an opinion, you want to do it, and vice versa. Sometimes I have patients who come from North Carolina who don't want to travel all the way down and they go elsewhere. That's fine. Well, but what you don't want to do is go from someone who does 5 HIPECs or someone who does 30, 40, 50 HIPECs a year to someone who does 5 HIPECs a year and get a second opinion. You want to go to a center that maybe only does HIPECs, right? So does that make sense? If you're going to go for a second opinion, go to a higher volume center or an equivalent volume center, I guess, but you don't want to go to a lower volume center. That's all. Because
Dr.
it doesn't
Wyatt,
make sense. Yeah.
I'm so sorry. One of the questions that comes up quite a bit, and I'm sorry to interrupt,
No,
is when, you're discussing the cytoreduction, the process, what organs will or will not be possibly removed via the consent. But one of the questions and concerns that people have is that when they're in the appointment and they're discussing, they're going to remove the duodenum, they're going to take out the spleen, and what effect that has on their body post-operatively. Like, what will they lose by having a splenectomy or a cholecystectomy or a Billroth 1 or 2?
Sure.
So they don't understand that. And how do you discuss that with your patients? Because a lot of people don't realize that the involvement of the small bowel and the nutrient and the malabsorption. So that's a big question that we've been talking about lately on the Zooms.
It's a great question. So there are 2 different types of doctors and 2 different types of patients. There's some patients that don't want an answer to any of those questions.
Right.
And they're scared and they just want you to take a look. And if you can do it, great. And they're willing to do whatever they need to do to be able, it doesn't matter to them, the quality of life afterwards. They just want this gone. And determining that, and then there's some patients that really want the details. And I err, as my patients here can tell you, err on the kind of the side of saying that people want to have kind of as much information as they can understand.
Right.
Just like, look, I go to my, I use this analogy. If I go to my mechanic and I show them my car and there's something going on with the car and they start talking to me about carburetors and spark plugs and all these other things, I'm like, whoa, what the hell are you talking about? Right. I don't understand that. It's not what I do for a living. Right. It means nothing to me. So I do my best to try to put it in terms that people can understand, but I'm not perfect. Don't pretend to be. I try to do the best that I can to give as much information as possible. For example, if I have a patient I think is going to need their spleen removed, I explain about what, the term is post-splenectomy sepsis, but what I explain is that you're going to need, various vaccines for the rest of your life, off and on for a certain amount of time, at a time that eventually your primary care doctor will give you to decrease the risk of getting infections that the spleen takes care of. Okay. So that's a pretty easy one. The harder one is when you're talking about removing a fair amount of the distal bowel, the small bowel and the colon, which can cause a significant quality of life issue. And patients have malabsorption, they get diarrhea, they have all these other things. And the truth is, so what I usually tell patients is that, look, we're not going to know what your new bowel habits are going to be for about 3 months. And it's going to be sometimes diarrhea, sometimes constipation, sometimes all these things. And sometimes it may end up being diarrhea that we have to use medications to control. And we have to do kind of trial and error to see what the issue is. And we work with it. And sometimes I can deal with it. And sometimes I have to have one of my gastrointestinal associates deal with it. But we can almost always figure it out over time. But I tell people that you're not going to feel like yourself, usually for about 3 months after the surgery. For about 4 weeks, I usually tell, and I go through all this as people can attest. We take about 45 minutes to an hour to discuss what to expect, after surgery and during surgery. It's kind of like when we were pregnant with our first child, you had the what to expect when expecting. And I think it's very important to have the same thing. The more you understand, even if it turns out that you can't do it, the more you understand of what's going on with your body, the easier it is to deal with both the complications after the surgery, as well as just dealing with the surgery itself and the changes that happen afterwards. And so I do my best to try to get through that. I'm not perfect. None of us are, but I take the time and I try to answer questions. And sometimes patients think about it afterwards and then they email me or or whatnot, and then I call them up if necessary, or sometimes we just talk about it. But that's what I try to do, to go through what I think is the most likely. And just as an example of that, I always talk to patients about ostomies. Whenever I do a HIPEC, every one of my patients, even if they have minimal disease, gets marked beforehand.
Yes.
And we talk about it. And I tell them, I said, look, percentage wise, I think you're about a 5 to 10, or, if there's a lot of pelvic disease, up higher than that. But I don't want you to hear about it for the first time if we have to do it. And more importantly, if we don't mark you beforehand and it's in a crease or in a bad spot, then you can't deal with it. It's a horrible quality of life. And so we try. Now, are we perfect? Obviously some things change after surgery. If you've had a lot of ascites, you may not know where your creases are or things like that, but we do our best. And also we have a wound ostomy care nurse that works very close to us. We have a nutritionist that works very close with us. And so we try to kind of a team that can deal with all this. I think that most places that do a lot of these surgeries, and again, it's not only HIPECs, it's the same thing with liver surgery or pancreas surgery or gastric surgery. You have to have a team that can deal with patient issues afterwards, because otherwise it's not good for the patient.
Thank you.
Is that a helpful answer?
Yes, I wanted to put that out there for others.
Yeah. And so we spend a lot of time, Mark, other people can say that, we're not, I always bring up the fact that I may not be able to do the surgery also. And I try to give a percentage based on the imaging of what I likely think it is. Because unfortunately, we can sometimes tell based on the imaging whether or not where we're going to have the trouble and what we think the likelihood is. And the other thing that's important is to know your not limitations, but know that you're not God. So I always have someone come in, one of my partners. If I find that I can't, for example, get things out of the porta hepatis, so there's stuff disease, I have one of my partners come in and we take a look together. I never abort an operation unless it's obvious, way beyond what we should be doing, without having another opinion of a very experienced surgeon just like me, who comes in and takes a look as well. And I think that's important also, to make sure that we don't abort an operation if we think that maybe it just needs four hands to deal with it. Because sometimes you can't do everything by yourself. You do need another experienced surgeon to help. And we have residents and fellows, but sometimes you need an even higher level. So that's how I do it. And if I've aborted the operation, I've had another experienced attending look at and agree that it's the right thing to do. What else? So does the spleen help with immunity against bacterial viral? Bacterial, mostly. They're encapsulated bacteria. So Neisseria meningitis, pneumonia, and strep pneumo are the main ones. And so you have to get vaccines against those. Every so often, there's a protocol on the CDC website. You initially get vaccines. We try to do it if we have a high suspicion we're going to have to take out the spleen before surgery, we do it prior to surgery, about 2 to 3 weeks before surgery. You need at least 2 weeks for the immunity to stay up, and then we do the second vaccines afterwards. If we really know in advance and we're kind of pushing it, if it's a low-grade tumor, then we usually do both vaccinations before surgery, and then we do the surgery, and then you get what are called boosters. So every so often, just like you get a pneumonia vaccine after the age of 65 every so often, and for those who don't have this disease process, it's the same thing with the splenectomy.
Dr. Weiner, I want to read one comment, and then I'll turn it over to Adele to wrap up.
Sure.
One person wrote, "Excellent presentation. Thank you, doctor, for your expertise and your thoughtful responses and generosity with your time. God bless your career helping patients." I think everybody here will agree with that. I'm going to hand it over to Adele to wrap us up.
No, absolutely well said. Dr. Weiner, we can't thank you enough for spending so much time with us and spending this one-on-one time to answer our questions and explaining things in a very plain English way to help us, understand this and continue to give us hope with regard to skilled surgeons like you and the advances that are being made. But our heartfelt thanks for all the time you spent with us today.
More than happy to take emails. I'm also the clerkship director for general surgery. It's kind of a little bit of crazy time right now for our students. So it may take a little bit of
Yeah.
time to get back, but I will email back.
That's so generous.
Adele, can I say one thing?
Sure, Katinka.
Thank
Hi,
you.
Katinka.
Hi, Dr. Weiner.
How are you?
I just wanted to say, guys, this guy is the real deal. And I've told you guys that before, and I'm gonna tell you in his presence, he's the real deal. Because I met him after finding this group, not knowing I needed a specialist. So he took my email before he even knew who I was. And we had exchanged back and forth. So I just want to thank you from the bottom of my heart for everything you've done for me over these years.
You're welcome.
And I'll see you in a few weeks.
Yes, ma'am.
And just as a reminder, if you didn't know, August is Appendix Cancer Awareness Month. And so I think this was a great kickoff to raising awareness about appendix cancer during this month. And continue to watch our social media, our website for posts about that. But with that, thank you everyone for being here today. Dr. Weiner, again, thank you so much.
You're welcome. Glad I could help.
Yes.
Have a
All
good
right.
evening.
Being here, everybody.
Yes, have a good evening. Bye, everybody.
Bye-bye.
Vaccine after age 65.
Just to let everybody know, the hosts usually stay on for a few minutes to wrap up after everybody has exited. Dr. Weiner, if you'd like to stay on, that's great.
Glad
But
to
if you
stay.
No, that's fine.
Yeah.
Certainly.
We're still recording, I believe.
Oh,
Yeah.
turn that off.